First of all, I just want to thank everybody for coming. I love the fact that we've got a bunch of different agencies represented here, and I think this is something I'd like to see a lot more of. I think it's a great way to coordinate care in the field is by training together, and getting everybody in the same room does a lot for interagency relationships, and I think EMS is probably the most primed area to do that, because we're forced to work together in the field, and I think we ought to be training together in the classroom. So I really appreciate the broad representation that we have here. Today's going to be a long day, and EKGs are a complex topic. One thing that I definitely would like to have happen is to have this be an interactive sort of engagement, okay? So if you have questions, raise your hand, interrupt. I'll be asking you guys questions. Please respond, be loud, right? That way this is recorded, and I want people to be able to hear your questions too. I want people to be able to hear your answers. This is going to start out from very basic, and we're going to progress to a much more complex, detailed interpretation of the 12-lead EKG. But I think we get in the habit with EKGs of recognizing patterns. And the problem that you can fall into, or the trap that you can fall into, is that if you don't recognize the pattern, you can't interpret the EKG. So that really limits you to what you know and recognize, and not the bizarre or atypical that frequently shows up, and then you say, well, shoot, I don't recognize this, I don't know what it is. So to really understand and to own the concept of the EKG, you really have to start at a foundational level and make sure we're building off of something solid, okay? So that when you are presented with something atypical, particularly something atypical in a critical situation, you know how to dissect that EKG and come up with some sort of intelligent interpretation, okay? And I'm not saying that you have to be right, and there will be ongoing debates on EKGs forever between medics and ER docs, between ER docs and ER docs, between ER docs and cardiologists, between cardiologists and electrophysiologists, and even amongst the electrophysiologists, they'll all debate and discuss a 12-lead. And the reality is, it's another tool, and we want to own it and understand it so it can help us do our job better, right? So being right is not the most important thing. Understanding the EKG is, and how to apply it to your practice. So what I'd like to accomplish today, as we go through this, is to build a solid foundation and then start to develop off of that, okay? So initially we're going to get into the very basics. Basic EKG interpretation. We're actually going to start off before rate, rhythm, axis, and intervals. We're going to actually start off with cell signaling, okay? Action potentials, channels, membranes, basic biology, cellular biology, okay? Because that is really what the EKG represents, is what's happening at the cellular level of communication. I'm kind of a follower of the Dubin's strategy for 12-lead EKG interpretation. So I like this rate, rhythm, axis, intervals, ischemia platform for interpretation. So that's the way I tend to teach. After we get into that, I want to go over tachyarrhythmias. We're going to get into some of the finer details of VTAC versus SVT with aberrancy, which is a very complex topic, and there's a lot of mystery surrounding what that means. But I think this is a good forum to discuss that. We'll talk about the bradyarrhythmias and the blocks. We're going to get into left bundle and right bundle, because I think particularly as medics, you kind of get a sense of what that's about, but you don't really own it. And I want you to be able to own that topic, because that's something you're seeing all the time, and that has a very real possibility of impacting how you treat a patient in the field. So we're going to go over this in some detail. We'll talk about ischemia, The reality is you guys are really good at ischemia. You're really good at identifying ST segment elevation. There's some foolers in there that get us tripped up periodically, so we're going to go over that. But this is not going to be a lecture about identifying inferior, anterior, and lateral STEMIs, because you all know that and you've proven that. That's why we have such excellent door-to-balloon times in Spokane County. You guys do that very, very, very well. So I want to focus on some of the things where we have room for growth, right? So we'll talk about the foolers. And then I'm going to throw in a few other things in there that are not ischemia related, but also potentially fatal. So, where to begin? The most basic part of cellular signaling, the action potential. So here we have plotted out a nerve cell and a cardiac myocyte. Now, the nerve cell is the Olympic athlete of cellular communication, okay? That is its sole job, is cellular communication, right? So that you see this very efficient spike here of a depolarization, which is propagated then down that axon and gives you immediate cellular communication, right? The cardiac myocyte, while it is very good at depolarization, takes a while to recover from that event, right? So if you got your Olympic athlete sprinting, he does his 100-yard dash, he's done, he's recovered, his heart rate's back down, he's ready to go again, right? Your cardiac myocyte's going to be gassed a little bit, it's going to want to pause, okay? So there's a physiologic difference between the two. You've got to allow for a little bit of repolarization time for the cardiac myocyte. Part of that is because I need to fill up that pump before I squeeze it again. So there's an innate need to have some delay there on the end, okay? But what we look at when we look at an action potential here is the gradient of charges across this membrane, the cellular membrane, and the time it takes to change that gradient or change that polarization, okay? So when I am polarized, then I have a predominantly negative charge inside my cell. When I'm depolarized, when I propagate that signal, right, when I depolarize the cell, I see a spike in that charge, which actually approaches zero, overshoots it a little bit, and then I return to repolarized state, right? So you got to think of every action potential as like a spring-loaded trap. It's just ready to go, right? It's in a polarized state, ready to send out its message. And as soon as I spring that trap, my signal starts, okay? So that's how you have to view depolarization of a cell. Does that make sense? So how do we set that up? How do we set up these charges? How do we make a polarized cell? And the way we do it, here's a very rudimentary drawing here, but the way that we do this is by setting up charges across this cellular membrane. Now the cellular membrane, remember we call it a lipid bilayer, okay? So you got a lipid bilayer cellular membrane, and there's all types of channels across this membrane, right? And what I end up doing is I shuttle sodium ions out and I bring potassium ions in. Now the way this happens to set up a charge, because they're both positive charges, right? So you would say, well, if they're both positive charges, how am I creating a difference? Well, the reality is I'm putting 3 sodiums out for every 2 potassiums in, okay? So I end up taking 3 steps forward and 2 steps back, 3 steps forward, 2 steps back, and if I do that enough, I have a net difference of 1 charge, okay? And if I can do that over time, or I can do that thousands and thousands and thousands of times, then I generate a gradient. The other thing about this is that my potassium ions will slowly leak back across. You'll get a little bit of sodium leak, but you'll get mostly potassium leak. Potassium says, I'm too crowded in here, I want to leak out, okay? And as I shuttle that potassium in, it slowly leaks out. But the sodium doesn't leak as well. So I'm actually able to generate more of a gradient because of that leak as well. Does that make sense? And eventually I set up a negative charge so that I'm negatively charged in the cell compared to outside the cell. That is a resting membrane potential. Your resting polarized state. Okay? This is the trap, spring-loaded, ready to go. All it needs is a signal to propagate that to the next cell. Okay? Does that make sense? So we talk about the sodium-potassium pump, and this is how I generate that charge within the cell. This takes energy, right? This takes energy. Sodium-potassium pump. Here's the inside of my cell with the cytoplasma, and here's my extracellular fluid, right? So I shuttle in 3 potassium, I shuttle in 2 potassium, I export 3 sodium for a net difference of 1 charge at the expense of ATP, which is the fuel for the cell, right? So I'm breathing in oxygen so I can make ATP. I breathe in oxygen, I take in fuel, glycogen, glucose stores, I make ATP with it, right? We're not going to cover the Krebs cycle. I won't put you through that misery today. But essentially, this is the fuel that I've created, and this is how I'm going to burn it, okay? This is one of the many ways I'm going to burn fuel, is to generate a gradient across the cell so that it can signal and communicate. It's set up to signal and communicate. So a cardiac action potential looks like this. I've got my resting state of approximately negative 90 millivolts. That's the charge that I'm set at. And when I get triggered to signal, I open channels, okay? I open particularly fast sodium channels initially. So in my resting state, that's closed. When I'm depolarized, this channel opens, and I get a flood of sodium into the cell, okay? That sodium floods in and changes what was a negative gradient and brings it closer to 0. And actually, you get a little bit of overshoot. And that overshoot happens when you start to add calcium and potassium to the mix. So this is a very basic picture. There's many more channels involved, but this is a basic picture of how that cellular signaling process happens. Okay? So I get a flux of positive charges across the membrane, and I depolarize the cell. The key to remember with cardiac conduction, that was our cardiac myocyte, right? That was the out-of-shape athlete, so to speak, who is a mix of contractile tissue and cellular signaling, okay? But what's important to understand about the heart, and particularly as it plays a role with EKGs, is that there are different portions of the heart with different action potentials. And this is how we distinguish nodal tissue from tissue of the bundle of His, or the His bundle, the bundle branches, the Purkinje fibers, and the myocytes. So we have specialization within the heart, and that specialization comes in with how they populate their membrane, what channels are there, and how efficiently they communicate. Okay? So variabilities in action potential thresholds allow different electrical characteristics in different portions of the heart. And that's why we get very specialized tissues. All right? This is important because, one, I have to have an area that propagates a signal. I have to have specialized tissue like the nodal cells, which are going to slow things down and delay it. I need a very rapid conducting system to get the message out to all the ventricles, and then I need my muscle to pump, right? So I need that specialization, and that takes place at the cardiac action potential, okay? And how that's where the difference is at in that tissue, okay? They're all muscle cells. They're all muscle cells. Just some of them are not really good at contraction. They're better specialized for communication, okay? And you can see that when you put two side by side. So here's an action potential of a ventricular myocyte who gets a signal, depolarizes, and squeezes, right? Now here is the action potential of the SA node, which we know is specialized tissue intended to propagate a signal, right? It's my pacemaker of my heart. And it happens to be the fastest pacemaker of the heart. That's why it is the pacemaker of the heart. So when you look at a pacemaker, you have to say who's going to start off, who's going to trigger this cycle, right? You think of it like a foot race. I got my SA node, I've got my AV node, I've got my His bundle, and I've got some myocyte, and they're all lined up in a race, right? The firing gun goes off. Whoever can depolarize first wins the race, and they set the pace. And then it starts over, and they come back to the finish line. Fire the gun. Whoever gets there first sets the pace. The pacemaker will always get there because it always depolarizes first, okay? Except in certain disease states, which we'll get into. And you can see that by this slow leak. There's a slope there. Do you see that? Does that make sense? So as opposed to the resting membrane potential that I have right here, shoot. Hold on, Dean just told me how to do this. I got to try it out. My felt tip pin. So instead of this relatively stable period of resting membrane potential, I have a resting membrane potential that has a leak to it. And that leak is what allows this cell type to reach a state of depolarization faster. And what you have to understand is that when I get to the threshold for that cell, I have what's called an all or none phenomenon, okay? So as soon as I hit that mark, all those channels open up together. You don't get a random opening of channels or a gradual opening of channels. It's an all or none phenomenon. If the requirement for the SA node is -40, when I hit -40, all those channels open up. They're voltage-dependent channels is what they're called. So I hit that state, I hit that mark, that achievement point, and they all open up, and then I get a dramatic reaction. That's really where it takes place. That's the trigger pull, okay? You just got to think the SA node has got an itchy trigger finger, right? And as soon as I get to that point where I hit the mark, I open all those channels and my signal propagates, and I depolarize that cell. I have a relatively stable resting potential on my other myocytes, meaning they're not going to do much unless nobody else steps up to the plate, okay? There's always a little bit of a slow leak, but it's not near the point it is at the SA node, okay? Does that make sense? See a lot of nodding yes, okay, good. This phenomenon is called automaticity, okay? The ability for this specialized tissue to depolarize without an external influence is called automaticity. That's why the pacemaker can have a signal that sets out a cadence and continues to beat from the time you're embryonic tissue to the day you die. That's automaticity. And that automaticity is attributed to this leaky membrane and the ability to approach that all or none threshold for depolarization, okay? It does not maintain that resting state well. This spontaneous depolarization in the SA node specifically has to do with potassium, okay? They have a reduced permeability to potassium but still allow passive transfer of sodium and calcium. So you build a net charge, okay? So remember how my depolarization of the other cell showed sodium and calcium channels opening up and allowing it all to flood in, but they were all gated channels. We have additional channels, calcium particularly and sodium also, that are a little more leaky. They have less integrity. They let more in than they should. So that leak is what gets our charge to that point. Okay? So once I propagate that signal within that cell, how do I spread that signal out throughout the heart? Right? It's not like I have an axon, like when I fire a signal in my brain, that single nerve can take and propagate that signal to wherever it needs to go, right? And it runs along that long axon. I don't have axons in the heart, right? It's a different cell. This is not nervous tissue. This is myocardial tissue, right? So how do I propagate the signal from one cell to the next? And the way we do that is between these gap junctions. And you can see here, if I look at the myocardial cells, this specialized cardiac muscle tissue, when I look at these seams in between, and you can see what's called gap junctions or connexons, gap junctions in between. And what that allows is the passage of that charge, that influx of ions, to pass to the next cell. And what happens when that influx of ions passes to the next cell? That membrane depolarizes. And so I get what's called propagation. So you got to think of it like the wave in a stadium, in a football stadium, right? Somebody starts the wave, and they propagate that signal to the person immediately next to them. And then the next person goes up, and you've all seen it, right? That's how we get cellular communication with cardiac myocytes, and we conduct. Now, some of that tissue has a lot more gap junction to it. It's specialized. You see less of the important filaments for contraction, these here. These are filaments and proteins used for contraction. I see less of those and more of the things that are important for cellular communication, like gap junctions. Okay? That is specialized tissue that we call the conductive pathway, right? His bundles, bundle branches, Purkinje fibers. So what it does is it's like a really fast group of people doing the wave that can do it real quick and propagate their signal much faster. Okay? So what I get is, with specialized tissue, I get rapid cell-to-cell conduction. Okay? And with muscle tissue, I get slow cell-to-cell conduction. And we'll talk, that's a very important concept when we get into wide complex, narrow complex rhythms, right? In general, narrow complex rhythms are utilizing that rapid conduction pathway, okay? Wide complex rhythms are using slow cell-to-cell conduction or a compromised, diseased conduction pathway, okay? And we can know a lot about where a rhythm is coming from based on that, okay? We'll get into that in a little more detail later. Does this make sense? How that signal that was an exchange of ions at a single cell depolarizes, activates that cell. That message is then propagated to the subsequent bystanding cells, and we can get that message sent out throughout the heart. How fast we send out that message depends on how well specialized that tissue is for communication, right? That makes sense? So if I take this area and I look at the cells of my SA node, and I have this membrane potential of a cell with automaticity, and you can see that gradual slope here, it sets out my signal, and my signal then propagates out through the atrial myocardium, right? And what I get is membrane potential of that contractile cell propagating through the atrium. And ultimately that signal is going to also meet at my what? The next most important conductive tissue. It's going to be my AV node, right? And that AV node has its specialized tissue that creates some delay, right? So this is how we propagate that signal, through intercalated discs and gap junctions from a depolarized membrane potential. So let's look at the rate of conduction of the various parts of the heart. Okay, I know this is a rudimentary picture, but it will make a heck of a lot of sense when we talk about rapidly conducting tissues. Okay, so I have a signal that starts in my SA node. My atrial muscle can conduct that signal through propagation, cell-to-cell conduction, and propagation of that signal at a rate of about 0.5 meter a second. Okay? So I get that signal all the way through my atrial muscle, and what does it do when it depolarizes? It squeezes. Okay? Well, that signal hits the AV node about the same time as my squeeze takes place. Right? But what happens with the AV node? Look at how fast the AV node propagates that signal. 0.05 meters per second. Significantly slower. So while my AV node is holding on to that signal and filtering it through, I allow atrial contraction and passing of that blood from the atrium into the ventricles. Okay? When I get that passive filling, or technically it's not passive filling, but when I get that filling, I then move that signal passes into my bundle of His. Now look how much faster the bundle of His and my bundle branches are than muscle tissue. Instead of 0.5 meter a second, now I'm 2 meters a second. Okay? Much quicker, a much faster process, right? And then I get into my Purkinje fibers, around 4 meters per second, right? So what this tells me is that a signal that can get onto this pathway is able to conduct a signal and distribute it to the entire heart at a very rapid pace, so that I get sequential contraction of that muscle, right? It's these Purkinje fibers. This is not a fair picture of Purkinje fibers. What you ought to be imagining here is a whole bunch of filaments coming off of these bundle branches. Okay, they're much more. What's a good analogy for that? I don't have a good analogy for it. This is not fair. There should be a much better representation of what the Purkinje fiber is. But the point is, if I can get onto that rapid conduction pathway, I can get that signal out, okay? And I can get it out fast. If I don't get onto this pathway, then I'm stuck depolarizing the heart at a rate of muscle, right? 0.5 meters per second, which is pretty slow comparably. Does that make sense? The problem is I can't get on to that rapid conduction pathway unless I get on through the AV node. Okay? That's how you get onto that pathway. I can't hop on at the left bundle or the right bundle. If I want to get propagation of a rapid wave, I got to get on at the AV node. Okay? It's like the on-ramp and an exit ramp to the interstate. I can't just drive on from a frontage road until I hit an on-ramp, right? It's the same thing with that. So now if we take our action potentials and we stack up our action potentials, you'll see what we are familiar with. The symbol of EKG that we're all familiar with, the PQRST, right? Now if I stack all those action potentials of all those specialized tissues, that's what I get, okay? So I have my SA node up on top. You can see that is nodal tissue. I have my AV node. Again, you can see also nodal tissue. I have specialized communication cells of my bundle branches, my common bundle, and my Purkinje fiber. And then I have cardiac myocyte tissue. And I'll stack those on top of each other. So my beginning of my P wave, which the P wave represents what? Atrial depolarization, right? you have to remember when we're looking at a QRS complex or a PQRST complex, what's deflecting on that EKG is primarily muscle tissue. Why? It's big. That's what's going to put out the signal. It's a bigger population of cells. So while I have very specialized tissue that's set up for cell signaling and conduction through the heart, the thing that's going to make the deflections on my EKG are depolarization of the muscle, because that makes up the predominant mass of the heart. Okay? So you'll see here, I have my SA node, propagates a signal. Okay? That signal reaches its threshold, and I set off my pacemaker. Right? When that pacemaker fires, it propagates that signal through my atrial muscle, and that atrial muscle contracts, and you can see that's where my P wave is at. Right? So I get atrial contraction. That atrial contraction converges on the AV node, and I get some AV nodal delay that occurs during my PR interval. But eventually that signal propagates through my His bundle, my common bundle, my bundle branches, and my Purkinje fibers, and results in depolarization of the ventricles. So this period, this P to R interval, your PR interval, is this silent phase of rapid conduction, AV nodal delay, followed by rapid conduction through the ventricle. Your initial depolarization and deflection here is going to be the depolarization of septal tissue in the heart, because that's what's immediately around that first set of conductive tissues, right? So my immediate depolarization is of the ventricular septum, and it spreads out from there into the ventricles, and I get a nice coordinated squeeze. Okay? So this is what the PQRST complex represents. So when you see that, you have to understand what's making that signal. So while these may all be individual cells, the combined signal that they emit, that we pick up on our leads, on our surface leads, is going to be in the form of the PQRST. Okay? So there's a lot of variability underlying the surface, but what shows up, the summation of it all, shows up as a PQRST on the surface leads. Does that make sense? Okay. Another thing about automaticity. We talked about the foot race of the various cells, right? The sinus node is going to be the fastest. It's going to set a rate of 60 to 100. That's why we call that sinus rhythm, right? We can influence the sinus node, and we'll talk about that later, by vagal activity. We can give it epinephrine. We can do lots of things and influence the sinus node, okay? The AV node and the His bundle, they have automaticity as well. And their automaticity is at about 40 to 60 beats per minute. What is that? What does that represent? A junctional escape, right? If I don't have the sinus wave leading the way, then who picks up the slack and becomes my next pacemaker? It's my junctional escape. That's because my junctional cells are the next in line in terms of the hierarchy of automaticity. So back to our foot race. Sinus node, my junctional cells, and then my Purkinje fibers, right? They're all lined up to run. Gun goes off. Sinus node trips and falls. Can't get up in time to win the race. So who takes it? Junctional cell takes it, right? He becomes the pacemaker. Now SA node is out, sprained his ankle. He's no longer going to set the tone for the heart. So I got my JV guy in there, right? And then if JV guy goes down, then who do I got in there for backup? I throw in the water boy, right? The water boy's like 20 to 40 beats per minute, right? And at least I don't forfeit the race. I got someone to throw in there. Not the fastest guy, but he gets from point A to point B. And what does that represent? My ventricular escape. So that is automaticity, right? Every beat is the beginning of a new race. Once I depolarize, I come back to the starting point. It's a new race. Whoever gets there first sets the pace for the heart. Because once I depolarize, there's that period of time where I have to repolarize. And I am not susceptible to another signal. Okay? I've got to recharge. I got to get back to where I'm in a depolarized state, and I cannot transmit a signal. It's not like that neuron that we saw in the very beginning. That neuron can come back to a resting potential very quickly and receive its next signal very quickly. That's why we can think faster than we speak, which sometimes gets us in trouble, right? So think of that. You think faster than you can speak. That's the difference between the neuron and the heart, I suppose. That's a terrible analogy, too. I'm full of them. So we talk about conduction, and we talk about narrow versus wide, okay? The narrow QRS indicates fast conduction through an efficient pathway, okay? Remember, this is on a time milliamp axis, right? So if I can depolarize over a narrow period of time, that means I'm faster, right? Narrow complex means I send that signal faster. If I'm wide complex, like in a bundle branch block, right or left, I become a wide complex QRS, which means it takes me longer to propagate that signal through my ventricles. Okay? I have faulty conduction, or I'm ventricular in origin, and I'm depolarizing the heart from the ventricle, which is only cell-to-cell depolarization. Okay? So then I'm doomed to be slow, right? So wide complex is either faulty conduction or ventricular origin. Okay? And we will talk about how to differentiate these two, because sometimes this can be complex. We'll get into things like supraventricular tachycardia with the left bundle branch block. How do I distinguish that from ventricular tachycardia? Because they can look very similar, okay? So we're going to get to that, but we got to understand this first, okay? We'll take breaks too, I promise. So here's the Audubon, right? Fast conduction or fast signaling through an efficient conduction system versus slow signaling through ventricular myocytes, right? Clearly the bottom guy is French. See all the vineyards down there, right? I think that's I shouldn't say things like that. But he could be Scottish too. So when I look at this rapid conduction versus slow conduction, what is a bundle branch block? Well, a left bundle branch block, you can see where I have a faulty area of conduction. So what do I get when I get this? I get rapid propagation of a signal from the atrium through the atrial muscle cells converging on my AV node, a delay, subsequent transmission of that signal through propagation into the His bundle, but then only staying on that rapid bundle of the right bundle branch to depolarize the right ventricle. The rest of this is going to be slow cell-to-cell signaling. Okay? So what do I get? I get a wide QRS complex. That makes sense? So key points to take away from this part. Normal rapid conduction is going to be indicated by a P wave followed by a narrow QRS complex. That tells me that I have a signal that started on the atrium, took the on-ramp to the Audubon, got on that rapid efficient conduction pathway, and transmitted that signal all the way through the myocardium, right? That's my narrow complex signal that begins in the atrium. Absence of the P wave suggests that I have an ectopic origin of a rhythm. So if I don't have an organized P wave, then my rhythm began somewhere else. We talked about a junctional escape. It does not have a P wave. Why? Because that signal didn't start with AV node and atrial depolarization, or SA node and atrial depolarization. It started at those junctional cells. And so I don't have a P wave. In fact, I might have a late retrograde P wave, right? Because I depolarize that atrium late and backwards. So instead of being in front of the QRS complex and upright, it's now behind the QRS complex and inverted. We'll talk about axis, and we'll talk about vectors and why those things flip the way they do. That's not important right now. But what you need to know is in the timeline of events of that PQRST complex, normal is PQRST. But abnormal origin could be demonstrated by QRSPT, okay? You can throw that in there depending on where that signal began. Or in the setting of a ventricular escape, all I get is a big, ugly, wide QRS complex, right? And then I know this is a ventricular origin rhythm. Make sense? So that wide QRS suggests inefficient conduction or a beat that originates in the ventricles as a PVC or some other ectopic ventricular source. Okay? Intervals. I just lost my screen. Oh, there it is. So intervals are the anticipated expected times for each of these deflections to occur, right? So deviations of normal are going to represent some sort of pathology within my conduction system, okay? This is going to be blocks, long QT syndrome, Wolff-Parkinson-White syndrome. These are all going to manifest as faulty or inappropriate intervals, okay? So it's important to know what your normal intervals are, but don't memorize the numbers, okay? When you do intervals, you ought to have a quick way of saying that's normal, that's not normal. The intervals that are important to us are my PR interval, okay? My PR interval should be less than one big square, okay? One big square, 0.2 milliseconds, right? I want one big square. Anything beyond that, I know I am in the range of a long PR interval, okay? Which would be first degree AV block, right? Now, what if I have no PR interval? That's bad too. That's a short PR interval, right? Then that's going to be identified as no lag period here, right? There will be some cell signaling that takes place there, some sort of depolarization of the ventricle will take place there, and we'll talk about that with Wolff-Parkinson-White. Wide QRS we already talked about. What about my QT interval? My QT interval is the interval from the beginning of my Q wave to the end of my T wave. What does that tell me? Something that is faulty with the repolarization phase of the heart, right? And we know that people with long QT are prone to potentially fatal arrhythmias. So I better be aware and know what abnormal is if I've got somebody who just overdosed on a drug that prolongs your QT. I ought to be anticipating the fact that this person is at risk for arrhythmia. Because if I'm not, they're going to go into the arrhythmia. I'll be chasing my tail wondering what the heck happened to this guy who just looks sleepy and is now unresponsive in VFib, right? I want to anticipate that. I don't want to be looking for pads, taking them out, trying to slap them on. I want to recognize long QT early, have pads on, ready for the guy to go, so when he goes, I shock, right? So anticipating what potentially could happen is critical, and intervals will do that for you. All right, before we take a break, who's this guy? If you are a previous medic student, you can't answer this question. Or Dr. Gover, you can't. Who's this famous Dutch man? Who said it? Eindhoven, right? And who's Eindhoven? Eindhoven's triangle, right. So Wilhelm Einthoven won the Nobel Prize in Physiology or Medicine in 1924. He discovered and demonstrated that each individual has their own characteristic electrocardiogram. But the electrocardiogram of all individuals in the main conform to a general type, right? So what we're studying now, we are now saying that we know what's normal. Everybody's a little bit unique, but we know what's normal. And he published an article that said we can make inferences about potential disease states based on deviations from what is expected, which is what we're doing today, right? So Wilhelm Einthoven is the guy who tied EKGs and what was his string galvanometer, which is now the EKG, and identified pathology via electricity, right? So here's what his limb leads were. His limb leads were buckets of water. So my limb leads went into the buckets, my left leg went into the bucket, my arms went into the bucket, and that's where we get Einthoven's triangle for leads 1, 2, and 3, right? Wilhelm Einthoven and his string galvanometer. God, I wish I was smart enough to come up with something like that, you know? Instead, I'm just like, hey, let me tell you about what this guy did. No one's ever going to say, let me tell you about what Joel did. All right, let's take a little break before we get into vectors.